So you have a female patient who presented following road traffic accident, and she's known to have sickle cell anemia. Head CT showed a large temporal mass measuring 3.8 centimeter, and that was accidentally or incidentally discovered. How did you find sickle cell anemia?
Okay, so it's a hereditary hemoglobinopathy that causes mutation of beta globin, then promotes formation of deoxygenated hemoglobin, leading to symptoms like hemolytic anemia, microvascular obstruction, and maybe tissue damage.
Okay, that's good. What are the complications of sickle cell anemia?
There can be a vascular occlusive phenomenon. There can be a plastic phenomenon. Then there can be chronic tissue hypoxia. Then there can be also chronic sequestration crisis and susceptibility to infection.
Yeah, that's well done. So you have multiple crises that can happen. Vascular occlusive. This can lead to, triggered by mainly infection or dehydration or acidosis. And it affects, can affect your chest, can affect the hand, can affect the brain, can affect the spleen, etc. Sequestration crisis, it's very painful crisis, which leads to massive entrapment of sickle cells into the spleen and causing splenic enlargement. Aplastic crisis, this is pancytopenia, especially with patients with parvovirus B19. Chronic tissue hypoxia lead to organ damage and increased susceptibility to infection, especially with encapsulated organism. And this is due to autosplenectomy. You just want to be like, more comprehensive when it comes to this question. What's the mechanism of autosplenectomy?
Okay, so first it happens in early childhood, in which the spleen is enlarged. Then after that, in adulthood, due to chronic development of sickle cells inside the red bulb. Sorry, in early childhood, there is enlargement due to congestion in the pulp region. But due to chronic stasis and inflammation, there will be fibrosis and ischemia, leading to shrinkage of the spleening, leading to autosplenectomy.
Yeah. So early childhood, there will be some increase due to congestion, and later on time, there will be some sort of splenic infarction and fibrosis and progressive shrinkage. What is the surgical relevance of sickle cell anemia?
Uh, there is possibility of in most circumstances, there's possibility of osteomyelitis, avascular necrosis of the bones, and there's also increased susceptibility to infection due to autosplenectomy, and also leading to poor wound healing. There's also increased susceptibility to gallstone formation.
Well done. Well done. That's really good. And you can also add the avascular necrosis of the hip as well, can happen with why this patient is immunocompromised.
Because of autosplenectomy. So there's less production of some there's less production of products which help in infection, and also there's increase in infection of in encapsulated organism.
Yeah, well done. On the other side, the same patient had some a mass into the temporal lobe. Um, I think in this area, you don't have to answer all the questions. There are some of them just added for understanding, but we have multiple brain cells. I'm gonna explain this quickly. We have multiple brain cells. These can include astrocyte, oligodendrocytes, ependymocytes, which are the lining of the ventricles, and you have neurons and the meningeal cell, epithelial cells as well. All right. So when you're gonna talk about tumors, the tumors can be basically coming from any of these cells. You always want to classify tumor into primary and secondary. The primary tumor can come from the astrocytes, and this lead to astrocytoma. Can come from the
Yeah.
oligodendrocyte, can lead to oligodendrocytoma. Ependymal cells, ependymoma, and also the neurons can lead to medulloblastoma, and the meninges can lead to meningio or meningioma. Come from the
Yes.
cover of the nerves, right, such as acoustic neuroma, and you can also have lymphoma and pituitary tumors as well, which is usually adenoma. So it's benign in nature, malignant. Okay, and
Yes.
second, brain metastasis, which is basically the commonest type of brain tumor, is metastasis. All right. So this is just for
Yeah.
your understanding. You want to remember the cells, and therefore you will be able to remember the types of tumor: astrocytoma, oligodendrocytoma, ependymoma, glioblastoma, medulloblastoma, meningioma, acoustic neuroma, pituitary tumors, and also lymphoma. And secondary, commonest place that will, the commonest organ that can send the metastasis to the brain is the breast. Okay. Um,
Yes.
what is the most? I mean, this is basically the same question, but you can classify tumors into high grade and low grade, such as glioma, glioblastoma, and medulloblastoma, and low grade tumors such as meningioma, acoustic neuroma, pituitary, pineal regions, and all of those are usually benign in nature, but due to the narrow space of the brain and inside the skull, it's malignant in presentation, despite it's all benign tumors. What's the clinical presentation? That's a question for you, Arthur. What's the clinical presentation of the brain tumors?
So usually it depends on the rate of growth of the tumor. And in most circumstances, they will present either with a specific occupying lesion and also signs of rest intracranial pressure. So some of them, they might present with seizures and might present with neurological signs like lower limb weakness due to a specific occupying lesion. Then maybe due to increase in raised intracranial pressure, there will be signs like vomiting, early morning headaches, and also I might present with nerve pulses. Let's say like they might have papillary edema due to raised intracranial pressure or ineffective lateral gaze due to abducent nerve injury.
Yeah, well done. So you can classify the general signs and symptoms of intracranial pressure, such as headache, nausea, and vomiting, and local signs. Frontal lobe, they can have personality change. Parietal lobe, they can have motor deficit and dysarthria, and papillary edema as well, due to increased intracranial pressure on the progressive focal neurology, exactly like you mentioned. What if the tumor is left untreated? What's going to happen?
Okay, so the tumor will grow in size, then cause increased raised intracranial pressure, and then it will lead to brain herniation and eventual death.
Yeah. So if left untreated, it can basically lead to death. Bottom line, the biopsy was taken and it showed some squamous cells. Okay. Um. So what could be the origin of this tumor if it has squamous cells in it?
As you said, it might be secondary, that is metastatic squamous cell carcinoma.
Coming from where? Which organ? What could be the primary? At the beginning of this,
Maybe.
at the beginning of this session, I mentioned what could be the squamous cell carcinoma. Where could it be coming from? So squamous cell carcinoma comes from your skin and orifices. All right. So it can come
Okay.
from the skin and orifices, nasopharynx, lung, esophagus, and cervix. Uh, this can all lead to squamous cell carcinoma. Patient had wound infection following biopsy. What's the commonest organism for wound infection following biopsy?
Staph aureus.
Staph aureus. And the wound discharge showed some glucose. What did that tell you?
Showing some glucose. Uh, I'm not really sure. Maybe CSF.
Yeah, that's right. So it could be CSF leakage, and it's communicated with the CSF space. Okay, fine. Thanks, Arthur. Solomon wanted to participate as well.